waiting room clear out.
Hi, everybody.
Good afternoon.
Hello. Sorry, I was cutting it so close. I went to the calendar invite and I couldn't get the Zoom link wasn't on there. So I just quickly went to the website.
I'll check that link for you. Everything should be in your invite.
But yeah,
I'll
I'm
look
kind
into
of
that.
surprised because I usually use that. I mean, and I just quickly went to the website, but I'll double check that. It could have just been an issue with my computer too.
Okay. It does look like your waiting room is cleared. I saw you, Alicia, and Sherry log in, but that's all I have for now. If I
Okay.
missed anyone, if they want to let me know, I apologize.
And that does not give us a quorum, correct?
No, ma'am.
Okay, we have to have one more.
Yes, ma'am.
Okay.
Oh, I think Courtney's coming in.
Okay.
Oh, the waiting room just filled up. So let's give it just a second. They should all
Okay.
be with us. We are clear.
Okay. So, and we do have a quorum.
Yes, ma'am. Sorry, I muted myself.
Yeah, no worries. Well, good afternoon, everyone. Thank you for being here. If you are with one of the MCOs or a guest of the meeting, if you would just put your name and your affiliation in the chat, we would appreciate it. Happy New Year, everyone. Welcome to the Child Health TAC. We have a quorum, so I'm going to ask that we move to approval of the minutes from the November 8th meeting.
I motion that we approve the minutes.
And do I have a second?
I second it.
And all in favor, say aye.
Aye.
Aye. Okay. All right. The minutes have been approved. Thank you all. I think we have two presentations today. The report on the homelessness research project by Angie Parker or her designee. Is someone here with that presentation?
Yes, good afternoon. I'm Angie Parker. I'm the Director of Quality and Population Health. I know we've talked about the homelessness and issues regarding that. We have my designee who is presenting this today is Megan Frazier. She's in our research and analytics branch within the Division of Quality and Population Health, and she and her team have done a lot of work on this. So it's very high level. This came down to probably finishing it up this morning. So it's hot off the presses, and I will turn it over to Megan. Thank you.
Thank you. Welcome, Megan. And thank you for being here to present.
Good afternoon, everyone. Can you all see my screen? This is the first time I've shared on Zoom, so I'm a little new.
Yes, it looks great, Megan.
Awesome. Thank you so much, Rachel. Okay, so as Angie said, I'm Megan Frazier with the Research and Analytics Branch in Division of Quality and Population Health for DMS. This presentation, she said, is an overview of homelessness in Kentucky. In particular, it looks at the unhoused population that are Medicaid recipients and to show some of the efforts in the state to address the issue of homelessness. Okay, so on this first slide, we have the criteria for defining homelessness, and this criteria is set out by HUD, the Department of Housing and Urban Development. So they laid out 4 categories for defining homelessness. So category 1, they define as literally homeless, and these are people who are living in a place not meant for human habitation, in an emergency shelter, in transitional housing, or they're exiting an institution where they temporarily resided. Category 2 is an imminent risk of homelessness. So these are people who are losing their primary nighttime residence. This may include a motel or hotel, a doubled up situation, and this is within 14 days, and they lack the resources or support networks to remain in the housing. Category 3 is homeless under other federal statutes. These are families with children or unaccompanied youth who are unstably housed and likely to continue in that state. And then there's category 4, people who are fleeing or attempting to flee domestic violence. So they have no other residence and they lack the resources or support networks to obtain other permanent housing. So the data in our presentation, the main data, is from the Homeless Management Information System, or HMIS, and it was originally obtained and analyzed by DMS Behavioral Health Team. So what is an HMIS system? They contain information about the characteristics of each person who uses a program within the homeless services system. So this includes emergency shelters, rapid rehousing programs, transitional housing programs, and permanent supportive housing. Okay, in each state, the continuums of care are who manage the HMI software. And in this next slide, we'll go over Kentucky's continuums of care. Kentucky has 3 continuums of care. We've got Lexington, Fayette County, Louisville, Jefferson County, and then the rest of the state is a continuum of care called the balance of state. So these are organizations that coordinate efforts to address homelessness. And according to the Kentucky Housing Corporation, the COC regions are comprised of service providers, developers, community leaders, advocates, financial institutions, and homeless service clients. And you can see in the image to your right, those COC regions, Jefferson and Fayette County are to themselves, and then the balance of state is made up of 6 regions. So now we're going to get into the data. This is from the Homeless Management Information System. This is for calendar year 2018 to 2022. On your left, you can see in the table, we've got those 5 years, the second column there, total HMIS members. The next column are HMIS members that matched with Medicaid. And then you have the percentage of those HMIS members that matched with Medicaid. So if you're looking bigger picture, there were 78,282 unduplicated HMIS individuals identified in those 5 years. 49,445 of those were Medicaid beneficiaries. So that means that 63% of HMIS individuals were identified as Medicaid beneficiaries from 2018 to 2022. This graph shows a trend line for HMIS and Medicaid match members. So the blue line, which is the trend line, the Medicaid members in HMIS, and you can see that that is trending upward. Both the total HMIS members and those who are Medicaid beneficiaries have went up in that time period. This slide shows the HMIS members that matched with Medicaid by age. So these are the age groups, and you see highlighted there that the highest population was 25 to 40. And I think something that this TAC will find particularly interesting is that the 0 to 17 age group is the third highest for those in HMIS that matched with Medicaid. Okay, on this slide, this shows the service utilization for the HMIS members that matched with Medicaid. So you can see the colored blocks there at the bottom indicate service utilization. The dark blue are ER visits, so those were utilized the most often, while at the top you can see very tiny there, wellness visits and psychiatric stays were utilized the least often by the members who matched with Medicaid.
Can I ask a quick question? What is the
Yes,
difference
sure.
between preventative services and wellness visits?
Because this information is from behavioral health, I do not know enough about that to speak on it, but I can get that information for you for the next TAC. Or if someone is here who would like to speak on it, I don't know that there is, but I can still get that for you all.
Okay, thank you.
Okay. So this is a 5-year analysis, 2018 to 2022, of Medicaid spend on the HMIS population that matched with Medicaid. And you can see very large in yellow there. The majority was hospital inpatient spend. So that's at 48%. The next highest category is SUD, substance use disorder, at 18%. Third highest is ER visits at 15%. And that 0% on wellness visits doesn't mean there weren't any. It just means the data was so small comparatively that it kind of got squished in the making of this pie chart, but they're in there. Okay, that was the HMIS data. Now we're going to go into the MCO data, the managed care organizations. This slide is just showing that they have new contract language in relation to this population. So DMS is going forward with using the term unhoused person, and that is in their contract. That's what the slide indicates. Okay, so each MCO has 3 slides. 2 of the slides are in the presentation, and 1 slide has a lot of good information in the appendix. The appendix is quite large. And it just goes more into detail on their resources and outreach because they provided us with a lot of good information. So first up, we've got Aetna. And you can see in the top right, the number of unhoused members identified in 2022 was 1,089. The unhoused members identified in 2023 was 1,106. So that is a 1.6% increase between those years in the members identified as unhoused. If you look on the left side of the screen, our table there, it's hospital admissions, readmissions, and emergency department visits per 1,000. So we've got for 2022 and 2023, each of the MCOs will have this slide on their slide. And then to your right, you've got the top diagnoses for unhoused members, and we asked for both all services and the top diagnosis by paid amount. So for Aetna, for both fiscal years and for both categories, the top diagnosis for unhoused members was opioid dependence uncomplicated. And that is a trend you will see continued throughout the MCOs. So here's a very brief overview of the resources Aetna has for unhoused members. Again, you can see at the bottom there, additional information provided by Aetna concerning outreach and resources for the unhoused population provided in Appendix M. Each MCO has an additional slide in the appendix with more resources. So Aetna has care management, community-based resource referrals, and access to value-added benefits where eligible. When an unhoused enrollee is not reached, they are placed in persistent outreach where they are outreached to monthly for 6 months. Aetna provided us with some good data here. If you can see between 2022 and 2023, the number of those successfully reached increased, the number of those that they were unable to reach decreased, and the number of referrals made jumped quite a bit. So now we're moving on to Anthem. You see in the top right there, they had in 2022 1,130 unhoused members. In 2023, 1,225. So you've got an 8.4% increase between 2022 and 2023. Same thing in the left, you've got your hospital admissions, readmissions, and emergency department visits per thousand. And then the top diagnoses, like Aetna, for both fiscal years for all services and by paid amount for the unhoused members with opioid dependence uncomplicated. Here are some of the resources Anthem has for unhoused members. They've got the empowerment program. So this is for members when they exhaust all community programs. There's both housing and food assistance available. So that includes empowerment housing assistance, the Flex Fund, and then they have empowerment food assistance, a 12-month Instacart Plus membership with fresh produce boxes. There is a full definition of those in the appendix. And then 287 members were successfully assisted with housing needs through the Empowerment Program upon case closure in 2023, and unhoused members have access to VABs where eligible. For Humana, they had identified 1,250 unhoused members in 2022 and 1,551 in 2023. So you've got a 24% increase between 22 and 23 in those unhoused members. The top diagnoses, once again, for all services and by paid amount for those 2 years is opioid dependence uncomplicated. So here's some of Humana's resources for unhoused members. We've got VABs where eligible, so that includes criminal expungement services. They have a workforce development program with childcare and transportation assistance. And they have a GED testing benefit that includes a test pass guarantee and bilingual support. They did report that 0 members utilized those in 22 or 23. And they will offer housing assistance this year up to $500 per enrollee per year to assist with various housing expenses. Passport by Molina, they had 3,718 unhoused members identified in 2022, 4,104 in 2023, and there was a 10% increase between those years in members identified as unhoused. Their top diagnosis varies a little bit. There for all services for both fiscal years was opioid dependence uncomplicated, but by paid amount, it was sepsis unspecified organism, so a little bit different from the other 3. So here are some of the resources from Passport. You've got the case management team, their housing specialists. They provided a comprehensive list that is in the appendix, but some of the things that they do are identify and help members access community resources. They assist with completing applications and paperwork, assist with obtaining needed documentation, assist with other social determinants of health needs such as transportation, food, and household items. They support housing stability, and then unhoused members have access to VABs where eligible. So these included in 2022 a benefit to prevent eviction up to $750, though they reported this was replaced due to low utilization. And then for 2023, a benefit for members who were working with a housing specialist and met the HUD definition of homeless that helps with costs associated with applications. Okay. For United, their unhoused members identified in 2022 is 649. In 2023, that was 890. So that is a 37% increase between 2022 and 2023 in the members identified as unhoused. So their top diagnoses are a bit different. In 2022, for all services, it was COVID. And then for 2023, it was chest pain unspecified. By paid amount for both fiscal years, it was sepsis unspecified organism. So here are some of United's resources for the unhoused members. We've got for members that have been identified for case management, complex or chronic conditions, their team assists with helping members secure housing resources and coordinates as needed. They follow up to confirm that members are completing housing applications, securing resources, or working with community-based organizations on an as-needed basis. unhoused members have access to VABs were eligible, and they are launching a program with Kaizen for transportation assistance that is targeting members with housing insecurity and homelessness. Okay. We have WellCare. So their unhoused members identified in 2022 is 864. In 2023 it was 939. We have an 8.7% increase between those 2 years, between 2022 and 2023. And they also have some different top diagnoses. We've got for all services in fiscal year 22, it was alcohol abuse with intoxication unspecified, 2023 schizophrenia unspecified, and then by paid amount in 2023 was also schizophrenia specified, but in 2022 was major depressive disorder, recurrent severe without psychotic features. So here are some of the resources WellCare provided. They provide a variety of outreach services such as finding permanent housing, benefit assistance, and employment services. They work with the individual for up to 6 months to a year, depending on needs, or until they're housed, the member is unable to be reached or no longer request services. Some VABs are available. You've got state-issued ID cards, so newer replacement state-issued ID cards at no cost. This does not include driver's licenses. I'm sorry, was somebody speaking or asking a question, or did I just hear some reverb?
It was just a little bit of echo.
Okay, I
I've
just
got
wanted
them
to make
muted.
sure.
You're good.
Okay. This does not include driver's licenses to real ID cards. And then for cell phones, you've got a free cell phone with talk, data, and unlimited text for members 18 years or older. So here are some commonly requested services that unhoused members have requested from their MCOs, and these are things that I found over a variety of the MCOs when looking at their data. So unhoused members request housing, which means finding and applying for affordable housing. They need help with things like rental application, rent, and security deposit financial assistance. They request assistance with food security, transportation, requesting and forwarding ID documents, and they request medication assistance. Okay, so the Office of Data and Analytics had a really interesting project that we asked for some data from. It was the homelessness indicator. So this is a project that utilizes Kentucky's health facilities and services data to create a process to estimate the prevalence of homelessness in Kentucky hospital care. So using that, the HFSD, they created a data field to identify cases where hospital inpatients were experiencing homelessness during their episode of care. So the counts produced by this indicator are from episodes of care where ICD-10Z codes for homelessness are used. And on this next slide, we will just look at some of the data that ODA provided. So you can see in the left, the primary health insurance for these individuals was Medicaid at 68%, 18% had Medicare, and then 7% paid commercially, and 7% had self-pay, charity, or other means of paying. The top 10 most common diagnoses for the ODA homelessness indicator were a bit different, but very similar to the MCOs. We've got psychoses, alcohol, drug abuse, or dependence. You can see that pops up a few times in this data. Okay, so here's a summary of the presentation. There has been a steady increase in the number of individuals matching with Medicaid in the HMI system and those identified by MCOs between 2018 and 2022. As we stated earlier, 63% of individuals in HMIS were identified as also being Medicaid members. The top 3 age groups within HMIS that matched with Medicaid were 25 to 40 years, 41 to 50 years, and then the third highest was 0 to 17 years. The top 3 Medicaid spending categories within the HMIS population that matched with Medicaid were hospital inpatient, SUD, and then ER visits. as stated in the previous slide, 68% of unhoused individuals in ODA's homelessness indicator listed Medicaid as their primary health insurance in 2022. And the majority of top diagnoses for the unhoused population by both MCOs and ODA's homelessness indicator dealt with drug and alcohol use. So here are some current initiatives from DMS to address homelessness. This first bullet point kind of just reiterates the presentation. Kentucky Medicaid provides many benefits through MCOs to those who qualify. The Kentucky Housing Corporation has programs that provide emergency, transitional, and permanent supportive housing. And Kentucky has requested to extend the Team Kentucky demonstration. This was formerly called Kentucky Health. A new component has been added to address homelessness. The proposed amendment requests to implement a pilot program for recuperative care services, also known as medical respite services, for adult beneficiaries who are homeless or at risk of homelessness. So in the appendix, there's additional information about the KHC programs and the Team Kentucky demonstration. So DMS is also looking at other state initiatives to address homelessness. This is just a brief list of some of the state's efforts, and we look at these. We've got Arizona, Connecticut, Florida, Maryland, Massachusetts, Washington. This isn't comprehensive, but this is just for you all to see that we are looking into other state initiatives. So some very briefly, opportunities for MCOs to assist their unhoused members. They could increase collaboration with community-based organizations and collaborate with DMS on implementing a closed-loop referral process through Connect Resources to help refer members to community organizations that help with social determinants of health, such as homelessness. Okay, and that's all of the presentation. Thank you all for listening, and I just want to show you briefly the appendices here. There's quite a bit of information in the appendix, and this is for your all's benefit. So now I can open the floor to any questions or comments.
Great job, Megan.
Yes, thank you. That was excellent. I will open the floor to anyone who has questions, but I'm going to start off by asking, and you may have this information and you may not. We see that a lot of the homelessness is around substance and alcohol use. Do we know how many of the children that are living in homelessness are connected with those adults that have alcohol and substance use?
That is a great question, Donna. I do not have that information currently, but that also is something we could absolutely look into and provide that data.
Okay, thank you. I just see that as being additional, we talk about, the stressors in childhood and the, adverse childhood events, and those things I think unfortunately tend to stack on each other. So it would be interesting to know that data if it's there.
Yeah, we'll have to look to see how in depth we can get to that number, or it might be a little challenging, and it will probably take us a little bit. So just have a little patience with us as we investigate that.
Thank you.
I just appreciate the presentation was super thorough, and I love that it sort of covered each of the areas and each types of resources that are available from each program. It's awesome. Thank you.
Are there any other questions? I also want to echo that was so helpful and so thorough, and so we really appreciate all of I am sure there was a lot of effort that went into that presentation. And so I hate to ask questions that are going to require a lot more effort, but if it's easy data to get, that's great. If it's not, we can sort of recognize that sometimes those things go hand in hand, that there's poverty and substance use and other adverse events that go together. So if it's easy data to put your hands on, that's great. And if it's not, I completely understand. I don't want to make work for you, since you've already done so much work and given us all of this really helpful information.
No, it's no problem at all, Donna. The presentation is meant to, open discussion around the issue. So any further research into it is not a problem.
Okay, thank you again. Any other questions?
Donna, this is Leon from Anthem. Just from an MCO perspective, as we started looking at this and just trying to compare the normal ambient rates of hospital or readmissions or ER visits per thousand, it becomes pretty profound. Homelessness does contribute directly to the need for access or different things. I put this in the chat, but our observations were that we had 3 times the normal hospital admits per thousand with the unhoused population as a cohort when we compared it to our normal. And it's 17 and a half times the utilization for ER visits per thousand when we looked at our data. And so, as we think about the interventions of how can we help as MCOs, regardless, or as an organization, or as a healthy ecosystem, to the degree we could help that, we'll see reductions or dramatic reductions in unnecessary utilization. So this is a chronic issue when we compare it to just the ambient utilization rates. Whatever we can do to help our members get safe shelter is going to truly contribute to a better outcome. So I appreciate you even asking the question.
Yeah, thank you for that addition. A lot of times I know that patients who come to the ER do so because they don't have a medical home. And they'll come to the ER, and then many times they may have an issue that's, if you knew you had good follow-up and you knew they had a safe place to stay, you might be able to send them home and follow them up. So we realize that all of that, sort of plays into the whole issue of homelessness and does make those numbers go up. So I just appreciate it. And I think for many of us, I shouldn't say for many of us, I'll say for me, I don't think I realized how much work the MCOs were doing around this issue until we started asking the questions. And you all started sharing with us exactly what all you have been doing, and all the hard work and all of the support you've been giving your members. So thank you for that. And thank you for trying to help, your members address those kinds of issues, because you're right. Ultimately, it's going to lead to better care and less unnecessary utilization.
I agree that I had no idea what all services that were being provided. And in addition to the handout that we got this week, we knew about some of those value-added services, but or benefits, but I had no idea what all the Medicaid system as a whole was helping families with. And it helps us to know so that we can pass along that information that they may or may, I'm sure they get from you guys, but then it's forgotten or, just don't think of it. So it's great.
All right. Thank you again to everyone who had input. And we will move forward to the report on Kids Count Data Book, which I think may have some crossover information. Alicia?
Myself off mute there. Yeah, thanks, Donna. So I have some slides to run through. Let's get those up.
And Alicia, if you don't mind to email those to me, this is Erin, after the meeting, so I could post them on the website. I'd appreciate it.
Yeah, I can definitely do that. No problem. Okay, so hopefully you're seeing slides. So I am Alicia Watley. For those who don't know me, I'm a member of the Children's Health TAC, but also a staff member at Kentucky Youth Advocates, and KYA each year in November puts out a county data book. And the data book has been around in this format for many years. And we make sure I know how to get through. Yeah, my slides there. So I'll just do a little bit of an overview of what is in the book, and then I'm going to dive into some of the data to present to this group on what we have seen this year, what we highlighted and think is important for kids in the state. So the way that the data book kind of works is that it's broken into 4 main domain areas, which are economic security, education, health, and then family and community. And then each of those 4 has 4 data indicators underneath it. So there's 16.
That is proportionate to.
So there's.
I'm sorry, Alicia. Sorry, Alicia. Guys, if you're not presenting or speaking, please mute. Thank you.
Thanks. So there's 4 domains and then 4 indicators under each. There's 16 total indicators that are in the book. And then each of those 16 are broken down county by county across the state. So I'm going to be presenting on some of the more statewide data, but there is a breakdown at a lower level if folks are interested in checking that out as well. So there's always sort of a theme of what we pull out as how the data, looks at a larger theme for kids. And this year we really looked at a kid workforce. And what we think that means is anybody who intersects with kids on a regular basis in terms of how they are supporting them. So this is our healthcare professionals, our childcare professionals, our teachers, community support folks, anybody who works in a profession where they regularly work with kids. And really, this workforce is sort of in crisis in Kentucky in a lot of ways. You all have been hearing, I'm sure, in lots of spaces about healthcare provider shortages and daycare shortages and other things like that, where we're missing those key folks that interact with our kids. So we wanted to take a look at how some of the data that I'm going to talk about in a minute sort of is impacting that workforce that helps our kids every day. So the first thing that we just do an overview, of course, of what is the child population in our state right now. And this is from census data from 2022. So obviously we are almost 80% of our children are white in the state. And there's a breakdown by race there that you can see. Some of these are really, really small numbers. So it appears as 0%, but there is a small number next to the breakdown there. And then the first domain that we look at is economic security. So our 4 indicators are children who are in poverty, children who are in low-income families, and you can see below those exactly how that's defined. So children in poverty are below 100% of the federal poverty line, and those in low-income families are below 200% of the federal poverty line. And then children who are living in food insecure households, and also those who have a high rental cost burden. And so as you can see, all of these indicators have improved. And I should have mentioned that all of the data indicators that you'll see have a baseline data that is whatever was the most recent indicator as far as dates, and then the latest data that we have. Usually that's either a 2-year or a 5-year difference, depending on the data source. So most of these have improved over time. A lot of the numbers here, the latest data is 2021. And so a note here is that a lot of folks were receiving stimulus money during that time. So when we look at children in poverty, this is during COVID, during the height of COVID. And there was a lot of national news about this. There was a lot of news in Kentucky about this. A lot of kids were lifted above the poverty line due to federal stimulus. And unfortunately, that did not stick around. So we will probably see these numbers change again in the next cycle of data reporting. So that's just kind of a caveat to consider here. I'm going to move on to the next one. Each of our domain spreads, we also pull out a couple of recommendations of what we think could be worked on or things that we would like to look at. So here we want to focus in on the high rental cost burden and then also the childcare availability across the state. So a lot of Kentucky renters are in a cost burden household. And this is looking at things like how much their cost for their rent is versus their income. And so you can see this map across the state. There are some areas where, upwards of 60% of the county is in a cost burden household. Obviously that has a huge impact if they have kids in the home. So one thing that we are looking to see is some investment of state dollars in affordable housing, in the affordable housing and the rural housing trust funds, which already exist, but we don't typically see a lot of state dollars funding those things. And one thing to note here is that a lot of folks across the state, particularly in Eastern and Western Kentucky, had loss of homes or significant damage to homes during flooding and tornadoes over the last few years. And so the availability of affordable housing has become even more difficult for a lot of folks, especially in rural areas, as we saw a lot of buildings destroyed. And then, of course, when we look at childcare, we have a significant issue with childcare across the state. A lot of our counties are considered a childcare desert, which means that we have either no childcare providers, a very limited amount, so they have long waiting lists. So a lot of children are not able to find care. And so we need to see a pretty significant state investment in the childcare sector in order for childcare to continue happening across the state. We have a lot of centers that are at risk of closing. Again, there were over the last 3 years, a lot of federal dollars helping to sustain these programs because of COVID, and that money ran out in 2023. So we are seeing we're at that cliff of like, we no longer have federal dollars infused in the state. We really need to have something to sustain these programs. And what we're going to see is centers are closing, or they're going to have to increase their tuition rates pretty significantly to stay open. Then of course that impacts families if they don't have care. So if we don't have a pretty big state investment, we're afraid that a lot of these centers are going to face closure for that. Okay, so then moving into the education domain, the 4 indicators we look at are kindergarteners who are ready to learn, 4th grade students who are proficient in reading, 8th graders proficient in math, and high school students who are graduating on time. So as you can see, this is kind of a mixed bag as far as where we're at here. Kindergarteners ready to learn has gotten worse over time. We have a lot of young children who this also is very closely tied to things like childcare and what kind of preschool settings kids are or are not attending before they get to kindergarten. So if we can continue to look at what they're doing before they hit our public school systems, then that will help more kindergartners come in ready to learn. And then, of course, we see just the proficiency in core subjects like reading and math. There's a lot of conversations happening around this. I think COVID had a huge impact on the way that we were assessing students. Students slide in terms of their knowledge level and what grade level they were at with certain things. And then high school students graduating on time is improving. That number is over 90% now, which is great. So we are continuing to see more students staying in school all the way through and graduating. And then looking at a couple of specific things that we would like to see some focus on are really after school care. So we know that a lot of parents have to rely on some sort of after school care because of the gap between when their kids get out of school and when they get off work. And so this is really closely tied to the same idea of childcare. It's the out of school time where parents are trying to work and provide for their family and need some care for their kids. So we need to find some ways to continue to invest in these after school programs, because a lot of these actually are taking place at childcare centers. A lot of childcare centers offer before and after school care for older kids. So when we talk about investing in childcare, this is definitely kind of in the same realm of getting some dollars to the centers to be able to keep their doors open and offer that care to kids. And we also know that you can see the investment savings here, but investing $1 in out of school care time, states will see savings of up to $3 annually for those kids who are in a safe environment and they're learning and they have adequate supervision during that time. Looking at the health sector, We look at smoking during pregnancy, low birth weight babies, children under 19 with health insurance, and then teen births. And again, we saw a couple get better and a couple who are getting worse. Smoking during pregnancy is improving across the state. But I will say that we still have some counties in Kentucky that more than 30% of women are smoking during pregnancy. So there are still pockets of the state that have really high rates. And that's something to be looked at. But overall, we are seeing improvement there. Low birth weight babies stayed about the same. This is something that I know has been focused on in a lot of different settings across the state, and a lot of state offices are looking at that. Children with health insurance, this is another one that is the dates that we have here that we're measuring are going to look different today than they did when this measure happened in 2021. As we know, during COVID, there was no one who was able to be removed from Medicaid. The wind down of all of the PHE stuff last year and ongoing still is causing some folks to no longer be covered, whether that is because of some error, because we were missing data on them, or because they maybe aren't eligible anymore. I think that there's going to be ongoing conversations about the coverage here and how we're seeing kids covered. Kentucky has a pretty high rate of kids covered by health insurance overall. As you can see, it's like above 96% for the last couple of times we've measured it. But we do see disparities if you look at race breakdowns here. So our Latinx children are less likely to be insured than any of the other children in our state. So that's something that KYA has been kind of keeping an eye on to see what we could do to get certain demographics up a little bit higher as far as their coverage rates. And then teen births are getting significantly better. The rates there, less teen births happening across the board. This is a national trend. Kentucky is kind of in line with all the other states as far as this is just more folks are waiting later to have children. We're having less unexpected pregnancies, things like that are happening across the board. So that's good news. Two items we pulled out in terms of access to care when it comes to health. Both of these have to do with reimbursement rates for Medicaid providers. So we know that a lot of our children in Kentucky are Medicaid or K-CHIP insured, but only about half of those kids who are on Medicaid or K-CHIP should have are covered for dental care, but only about half of them are getting a regular dental visit. And so there's a lot of reasons for that, but one of the things is that we have a limited number of dentists providing Medicaid services across the state. We know that there's a lot of areas that it's hard to find a Medicaid dentist. And so we're looking at ways to increase the reimbursement rates for that profession. And then same thing with mental health. 1 in 6 Kentucky kids are experiencing depression and anxiety. Obviously, we've been talking about mental health for many, many months and all the ways that we can be looking at that. But one of the things we'd like to see is an increase in reimbursement rates for the Medicaid providers there as well to help expand the network and get more providers out there seeing kids. And then lastly is family and communities. And this one we look at birth to mothers without a high school degree, children who are in foster care, children who are exiting foster care to reunification with their family, and then youth incarcerated in the juvenile justice system. So a couple that I want to focus on here when it comes to foster care, Kentucky still has a very high number of children in the foster care system, and this is continuing to increase. You can see that in the numbers here. It's getting worse over time, and we're also seeing fewer kids who are able to successfully reunite with their family out of foster care. So we do see some needs there to continue to focus on that area and figure out how to provide supports and prevention so that kids are not entering foster care to begin with. And then when we look at youth incarceration, something I would like to just note is that although this number has gotten better over time, we are still seeing some disparities in terms of race of the youth who are incarcerated. So we're still seeing Black teens incarcerated at a higher rate than their white peers. So that's something to be aware of and something that we would like to continue to look at as to how we can reduce the disparities there. So one thing that we wanted to talk a little bit about is continuing to put money and resources towards diversion programs for youth who maybe do have a, get in trouble for something or have potential contact with the juvenile justice system. It is an incredibly difficult system to get out of once you're there. So the fewer kids we can send into the juvenile justice system, the better. And we also know that they are less likely to commit another offense in a 1-year period if we use diversion versus if they go through a traditional court proceeding. So that's just something to highlight, and we'd like to see some more investment in resources in those programs. So that is my overview. There is way more information in the full book. I have the book here to reference if I need to. There is a lot more information, and we also have a data center online that has hundreds of indicators that you can search through if you're interested or just want to learn more about the data that we have. But those are some of the highlights and things that I think could be important and help shape some conversations for this group. So I'm going to stop sharing, but happy to answer questions if you have them.
Thank you, Alicia. That was some good news and some not so good news. So thank you for sharing that and for kind of distilling. I'm sure there's so much information there, but I appreciate your efforts to distill what you thought would be most important for us to know. Does anyone have any questions or comments? And I guess my question to the TAC members is, do we see anything in either of these reports that would make us want to make a recommendation to the MAC based on any of this data? Other than please fix all of these things. The simplistic approach, right? I know that there's a push, I believe now, for universal preschool or pre-K. And so certainly that would be something I think that many of us on this TAC could certainly be supportive of. If that becomes something that becomes contentious, but I know that there's certainly a push to do that. And I think we would see educational indicators and other things improve with that emphasis on early childhood education.
I agree with that on the kindergarten. Also, there's so many things that are of concern, like foster care has been a problem for a long time. And the other one I was looking at, child care deserts, that's a real problem in Kentucky. Alicia, I mean, there's so many things and we can't do everything. I'm just trying to think how we can help the best, make a difference. Because some of these things have been listed for years and they're improved, some are improving. So I'm not sure what to say, but
yeah, absolutely. I mean, I don't know if there's a specific recommendation that stands out. Obviously we have a lot of areas that we see, could be improved, but I don't know which of those the mechanism is for the MAC necessarily. I guess that's a question that I would have is like, is there anything that we see as within the realm of what the MAC can look at or recommendations that would make sense in that space versus maybe somewhere else?
right.
Now, that's a good question, or that's a good point. And maybe Erin can give us some guidance on what kind of things are the purview of the MAC versus.
Well, honestly, when it comes to making recommendations, sorry, I got tongue-tied there. It really just depends on what the TAC would like to make. Now, my personal suggestion in having ran these is that I kind of agree with Alicia. Currently, there might not be a specific topic that we've talked about today that DMS can. Now, I'm sure there's lots of topics that DMS can work on. I guess I'm trying to figure out a more specific item. Where is it that you guys would like to focus? What is the issue or concern that you see that DMS can help moving forward? So typically things, I'm trying to think of a most recent, one of our most recent recommendations, for example, from the home health is they had a home, a supply, I believe it was a separate size of a diaper, an XXL, was not on the fee schedule. So they had recommended to the MAC that DMS look into adding that to the fee schedule. So things like that are, and that's just the one that sticks out in my mind because it was, I think, the most recent one that I touched. So, but it really just depends, you know, what the TAC thinks that DMS can do, areas that we can help excel. Again, you guys are the boots on the ground. You're out serving our members and know the obstacles that you see in your fields. So those items, you know, if say, for example, if homelessness is the topic that you guys want to focus on and move forward and bring to the meetings, maybe different ways that DMS, the MCO partners can better serve our community within the guidelines that we have, of course, with CMS and things of that nature, and always start those discussions. And then if a recommendation comes out of those things, we think DMS could do X, Y, and Z to improve A, B, and C, bring those recommendations to the TAC, vote, and take them to the MAC. Does that make sense?
Yes.
Okay.
And it sounds like there's already a lot of work going on around with the MCOs and with Medicaid regarding the homelessness, regarding homelessness and how to assist members with those issues. So, making that recommendation probably at some point would have made sense, but now that it's being addressed, I'm not saying it's being solved, but certainly there's a lot of work around that. Okay, well, any other questions or comments? It doesn't sound like perhaps there's anything that we've learned today that isn't already being, certainly that there's work around it. Anything else from any of the TAC members? Alicia, thank you again for this very helpful presentation. Without any other comments or questions, is there any new business? Okay. Without any new business, the next topic is general discussion of future topics. So would anyone from the TAC like to suggest a future topic for our next meeting?
I had mentioned this, I think, just via email to some folks, but I know you had said make sure and bring it up during January's meeting, about revisiting the administration of Medicaid services in schools through the expanded care opportunities, and how we're doing across the state, how many schools are taking advantage of Medicaid billing, maybe barriers to if schools are not taking advantage of Medicaid billing, and maybe just revisiting learning some of what's going on in that space. And I'm on a work group for that, so I think I could probably find somebody to speak to that topic, if that would be of interest.
What all services are you thinking about, Alicia? Like medical and then mental behavioral health?
Yeah, there's a big focus on the mental health pieces right now with the work group that I'm on. But I mean, the rules, to my understanding, is that pretty much anything is allowable in terms of like what could be billed under Medicaid in schools, but a lot of schools already have professionals on staff for mental health purposes for students, who would be able to then add Medicaid billing to their work versus, you know, hiring a APRN or something to have on staff at your school. But I think that mental health has definitely been a focus area there, but it could be broader, you know, if schools wanted to.
Erica, are you on the call today and might be able to address some of those just briefly? I know Erica Jones tries to attend as much as she can and always works with the school-based services. Not to put her on the spot.
Hi, good afternoon. This is Erica. I apologize, I missed the question.
They were just discussing school-based services and billing and utilization, and just if we gather that type of information, it might be a discussion moving forward for future meetings, excuse me.
Yes, so we do gather that information, and we report on that annually, and that's how we determine what our rates will be for the next school year. We are actually sending out a survey to all of the school districts. That's going to the administrators, principals, special education coordinators, and maybe some other staff. And we have a specific provider type in Kentucky Medicaid that is school-based services. And that is when a school district is the actual Medicaid provider and they bill for services. But we know that in some school districts, the district has contracted with other community providers to come in and do the services, and that community provider is doing the billing. So we may not see those and include that into our school-based services, even though they're being performed in the school setting. So what that survey will let us know is a truer picture of what is happening in the schools and what type of services are being provided and by whom. And we expect that survey to be going out a little bit later this month. So once we get those results, we'd be happy to share that with the TAC.
Erica, do you think that April would be a realistic time where you would have that information that you could give us?
Yes, so it may not be fully analyzed, but we'll have the raw data for sure by April.
Okay. So perhaps that's a topic for April's meeting, is just a discussion of school-based services throughout the state and county to county.
Certainly, yes, I can do that. Thank you.
Thank you, Erica. Okay, any other suggestions? Thank you, Alicia. That was a good suggestion.
We still have obesity, juvenile justice, obviously bullying and stuff on our agenda here as possible future topics. I don't know whether those seem priority or who we would have to talk about them.
So someone from DMS, are you all collecting information about high BMI or obesity in children throughout the state? Is that something that's an ongoing area of data collection or an ongoing area of concern? I know it's an ongoing area of concern, but
I believe it's a HEDIS measure that is Healthcare Effective Data Information Set as one of those HEDIS measures that is collected.
Okay.
So it is from that standpoint. We are concerned about, as you said, about obesity in general for our children and our overall population. So that is something in how we are considering how we address that through the quality review process.
So is that a topic that we think we could have some good data collected by our next meeting in April, or is that a topic that you feel like we should put off to a future meeting?
At this point, let us look at that. I don't want to, when is our next meeting?
Our next meeting is April the 10th.
There could be a possibility that we might have some data, but I don't, at this point, we would need to really look at that, to see what we could get. And how
Okay.
we best, communicate what is actually going on.
So
And so
perhaps
we
we'll
can certainly
put,
start working on that.
so perhaps we could put obesity on the schedule for future topics with the understanding that it may be April, it may be July.
In not, what specifically would you like to see regarding obesity in children? Is there something, some particular things that we could make sure that we're pulling out? Obviously, you know, something like what we did with homelessness, we can, you know, what the MCOs are doing to work towards that as well. We would include that, but any particular data. And, you know, and a lot of it does depend on how the providers bill it, if they put that code in, you know, for BMI. So, you know, we would be limited to that, but hopefully that, you know, that some of that is tracked and available in the claim system.
I don't know. I'm a little out of my league in talking about this, but it is related, and that is also what interventions are paid for or available for children with obesity. I am the transplant psychologist at Norton Children's, and we're beginning to have some issues with older adolescents being obese and not qualifying for a transplant based on BMI, but also their insurance not covering any weight loss medications, which I know are probably not even approved for children. So that's where I'm out of my league, but I know that they've wanted to experiment with some of those, but they've been kind of unable to, because it just, you know, the barrier is that insurance, their insurance is, which is often a type of Medicaid, doesn't cover it. I'm not saying that I'm lobbying that it should be covered, but I'd be curious what kind of interventions are available that are covered. Whether it's some type of exercise, or I'm sure I know in the value added services, there's some funding for, you know, like memberships at a gym and those sorts of things that could be helpful, certainly. But just curious whether that would be a related topic of interest to anybody about any types. I mean, the data, maybe the frequency and what we're seeing in the populations based on what pediatricians are putting and are coding, but also if there are things that are helped or mediators for that to help kids. In addition to, I know there's healthy eating and other funding for fruits and vegetables and stuff that were on the value added services sheet that we got recently, but just curious.
We can look at that.
Like I said, I am not someone
that may not be as much for children as there are for adults, but we can.
Yeah, and I'm not someone who can prescribe those. Dr. Grigsby could certainly talk more to that as whether it's a need or whether we're kind of in a different category with kids who are probably going to die if they don't get a transplant. And so we're looking at maybe some more extenuating circumstances for those kids in particular. So.
Well, and I think just knowing, you know, again, it's been very enlightening to hear from the MCOs what kinds of services and value added benefits they've done for other things, and what are they doing for children who have, you know, high BMIs and things like that. I think would be helpful. And certainly if that's an ambitious topic to be done by April, we certainly could put that in July's agenda. What do you all think? Just asking from the MCO standpoint as well.
This is Kelly from Aetna Better Health of Kentucky. We'd be happy to present on that. We do have some specialized programming, in particular in SCI, that we'd be happy to share with the TAC.
Yeah, and this is Stuart with Wellcare. We're talking about obesity, right? Correct.
Yes.
Yes.
Correct. Sorry.
If you really want to open up a can of worms, we can talk about weight loss drugs and GLPs, and we can go all day.
I don't know if I do. That's what I was saying earlier. Because I'm out of my league. Some of them may even cover it and I just don't know it. And it could have been these particular children who couldn't get it, you know, so I'm talking globally. I don't have all their charts in front of me, obviously.
Yeah, I mean, weight loss per se is not a covered Medicaid benefit. Of course, if you got diabetes, you could get prescribed a GLP, you know, to treat that. But weight
Yeah,
loss
but
per
I think
se,
we want to focus on children and obesity.
yeah,
Yeah. I think what they're trying to see is whether or not the MCOs are doing any targeted communication or services for children and obesity.
yeah, care management. We can
Well,
talk about bullying too.
Yeah, those two sometimes go together, unfortunately, don't they? So
Donna,
maybe, go ahead.
I was just gonna say on the subject of obesity, I think it would obviously be great to hear the data that was just being discussed and hear from what is available to Medicaid members and children. But all of that is that was just mentioned that I heard is like folks who are already experiencing obesity in childhood. But I would also be interested if there's any opportunities for Medicaid to help with preventing obesity in childhood. I don't know what work's being done there, or if there's anybody that can speak to how are we preventing children from experiencing childhood obesity and where Medicaid's role is in that.
And you know, we have, and other MCOs do, we have like food as nutrition or food as medicine programs where we teach, especially like new mothers and even pregnant mothers, and teach them about, we've got, you know, vendors, partners that teach them about healthy diet and how to cook and everything. And all, I mean, all the MCOs do this, and with the aim of also teaching the kid that it'll translate or, you know, pass on to the child as well. I know we all have initiatives like that.
Yeah, so maybe if other TAC members think it would be valuable, maybe it's hearing kind of both sides of like, what is the prevention that's happening? And then what services are offered to those who are experiencing childhood obesity as well.
And that sounds like I mean, I think that would be very helpful. And I think that sounds like a pretty full agenda item. So perhaps that's something we think about for July. And then maybe we focus on school-based services for April's meeting.
That sounds great.
Okay.
I mean, as I said, there are certain HEDIS measures that are broken down by BMI for age groups, and then counseling for nutrition for certain age groups, that we have that information from measurement year 2022. That could be part of it. We can look at that.
Yeah, that would be very helpful. Thank you. Okay. So I think we've got a good idea of what our next couple of meetings will be in terms of topics of focus. Anything else? We sort of already talked about recommendations, or not really having any recommendations to move forward to the MAC. Aaron, the MAC meetings again, have those gone to quarterly, or are those every other month?
They are still every other month.
Okay. Could
and
you?
ours is on the
Yeah.
25th.
Okay. Okay. Maybe if we could get those, I always, of course, think about this sitting at this meeting, and it's too late for me to get out of what I do, my clinical time on Thursdays. But maybe if you could share with the group the MAC dates for the year, and then planning ahead, I think we might be able to.
I can absolutely do that. Would it be easier for me to just forward the MAC invitation to the TAC as a whole?
Sure. Thank you. Okay, and our next meeting is April the 10th from 2 to 4. And are there any other questions, concerns, discussion? So I guess our next agenda item is for someone to move to adjourn.
I'll move to adjourn.
And do I have a second?
I'll second.
Okay. All right. And all in favor, say aye. Okay. Could the TAC members stay on briefly? And Aaron and we'll discuss the agenda for April. And then I will get that to Aaron so that we will have that taken care of for the next meeting. Thank you again to everyone who presented today, and thank you to the MCOs for joining us and for all the hard work you're doing for for your members and our children. So thank you all.
Everybody have a great rest of the day.
You too.